Welcome back to another episode of BackTable OBGYN. I've got with me once again Dr. Amy Park. Amy, how are you today?
Great. How are you, Mark?
I'm good. And we have our first repeat guest. Very exciting. Once again, Dr. Barbara Levy, good friend and colleague of ours, clinical professor of OBGYN at the George Washington University School of Medicine and Health Sciences, voluntary clinical professor, UCSD, Department of OBGYN, of Obstetrics, Gynecology, and Reproductive Sciences. That's a mouthful. Barb, how are you?
I am great. How are you?
I'm good, and welcome back.
Thank you.
And I think I met you towards the end of your tenure as RUC chair, and in a similar fashion, I got a letter from AGL saying, hey, we'd like you to go and be sort of apprentice to the liaison. I think Craig Sobolewski was tired of being the liaison, and they said, let's find someone who we can send. And I got the letter and was like, what is this? And again, someone said, in different words, just go. Like, I don't know, someone offers you an opportunity, take it. And so I show up to DC and I had the nicest room. It was not what we're supposed to get. I got there late, got an amazing room and a view of the Washington Monument to get to in DC to get to my first ACOG Committee on Health Economics and Coding meeting, and walked in and was like, what on earth is any of this? And it was you and it was others that just said, hey, just listen, this is important stuff. And it was life-changing for me, for my career, but also my understanding of all this. And so I'm going to play my role, which is of the dumb guy in the room, which is whenever I walk into that meeting, there were so many brilliant people. But for our listeners, I want to sort of back up a little bit and really talk about sort of how a bill becomes a law in that way, because we all go to med school, we all go to residency, and I won't speak for anybody else. I learned nothing about any of this stuff, about reimbursement. And so talk us through a little bit about just like the transition from because 100 years ago, doctors said, this is a business. This is not a thing that the government's going to provide. We want to make money off this for the most part, right? This is the AMA opposed just about every federal medical insurance option until the ACA, right? Was it for the most part?
Yeah. I mean, AMA was not in favor of Medicare in the 1960s. So I think you're right. I haven't done a deep dive into looking at the AMA's position on all of those things. But yeah, I mean, in the old days, there was the country doc who traded chickens and eggs for the work, and that worked out in rural areas. But as medicine has changed, as the number of years we have to train changed, and the total environment that we're living in was altered, I think there's been quite a long haul to get to where we are right now.
So can I ask, what was your role? Barb, you said that you were the ACOG liaison and you became the representative and eventually the chair. And then Mark, you were representing AAGL, or was it ACOG?
Craig was AAGL's liaison to the ACOG committee. So the ACOG committee had general members, and then they had subspecialty committee members. So like SMFM and SGO and all the different subspecialty societies. So I was going to be, I was thinking they were hoping, I think, that I would become the AAGL rep to the committee. And unfortunately for them, and fortunately for me, I had people like Barb and others on the committee who saw that I was interested, and I asked a lot of questions because I felt like, well, no one expects me to know anything. So I can just be the dumb guy in the room, which is what I was, and ask a lot of questions. And I think Jordan Pritzker said, you seem kind of interested in this stuff. And Barb said, you seem kind of interested in this stuff. And do you want to do more? And so I got my letter as an invitation to be on the actual committee, not as AGL's representative. And my invitation was to be the vice chair of the committee. And that was Donna, who was the admin, who was just like, don't worry, it's for your CV. Like, the vice chair doesn't do anything, In the first meeting as vice chair, a couple years in, the chair said, her first meeting as chair, she said, thanks, I'm actually going to step down and not be the chair. And Donna burst out laughing. And so I chaired that committee for 2 years. But what I learned was you don't have to know everything. You just have to know who knows stuff and make sure we eat lunch on time and make sure we catch our flights. And other than that, nothing's that important. But sitting in a room with the brain power, you and Marty Tucker, and there's so many others who are just like, incredibly just the institutional memory in that room was mind-boggling for me and what I learned. And then to come home, I'll leave the room thinking I'm the dumbest person in the room, and I come home and like I know more than everybody.
Well, can you just tell me like who has seats at the table and who doesn't have a seat at the table, and then how the sausage is made? Because I'm just fascinated. There's so much that goes into it. And then also I hear all these things about if you try and increase the number of RVUs for CPT code, it only goes down, and breaking open the codes. And there's just lots of different things.
Yeah, let's back up. So ACOG has a coding Committee on Health Economics and Coding. That ACOG committee reviews applications to the CPT Editorial Panel, and the panel is an AMA group that looks at applications. Anybody can submit an application for a new code, for a new procedure. So ACOG, the committee, looks at those applications that were applicable to the women's health space, and sometimes to others as well, to discuss them, and then also to discuss gaps. Are there gaps in coding that we should recommend a coding application to fill? And sometimes it's industry that comes to ACOG and says, we've got this device, we've got this, let's pick radiofrequency fibroid ablation as an example. That was a new procedure, new device, new way of handling fibroids. The companies were very anxious to get ACOG to sign on to say that this was reasonable. ACOG looks at the literature, looks at all of those things, and makes a decision about whether, and that's the committee makes a decision about whether to support, not support a code change application that goes to the CPT panel. At the CPT panel, every medical specialty society that has a seat in the House of Delegates may have advisors to the CPT panel. So ACOG has advisors that can comment on any application for any specialty at every meeting. The members of the CPT editorial panel are appointed by the AMA Board of Trustees, and they are nominated by specialty societies generally. When I left as chair of the RUC, the AMA asked ACOG to nominate me to be on the CPT editorial panel. Marty Tucker was on the panel for, I think, close to 10 years. Jordan Pritzker has been on the panel. We currently have, Janet is on the panel. And I am vice chair of the CPT editorial panel right now. So we have lots of OBGYN representation at the panel. The panel makes the decisions about whether codes are ready for prime time. So is there enough literature? Are there enough physicians performing the service to justify a Category 1 code? Category 1 codes, once they are passed, go back to the specialty societies for survey. And the survey asks people who perform the service to compare it to other services that they also perform. So it's a relative value scale. And so compared to a hysterectomy or compared to a myomectomy, where did radiofrequency ablation fit in terms of amount of time that it takes to do the procedure, the amount of preoperative work and postoperative work that happens, and the intensity of the work that's happening during the procedure. So all of those things are wrapped into a standardized survey that is sent out by the specialty societies to come up with a recommendation for work relative value units. That recommendation goes to the RUC, the RBRVS Update Committee, for assessment. The RBRVS Update Committee is populated differently than the panel. So the panel is all appointed by the AMA Board of Trustees. The RBRVS Update Committee has fixed seats for specialty societies.
And that's the RUC, as it's known, the
Correct.
RBRVS Update Committee, the RUC. Yeah.
Yep. And so we have, ACOG has a permanent seat at the RUC, as does surgery has a permanent seat, cardiology has a permanent seat, pediatrics has a permanent seat. And there are some rotating seats for the smaller subspecialties.
Like ENT or ophtho or something like that?
I think those two probably have permanent seats. I don't remember.
It's like 27, or at least it was like 27 specialties, but like at the time, 24 were surgical subspecialties. And then there was like peds, family medicine, internal medicine. And so shockingly, surgical things got valued more highly than primary care things. But so Barb, that's like an incredibly concise summary, but like for me, I think, and for others who I've tried to explain this to, kind of walking through the process, because I think there's some important distinctions for our listeners, and certainly some people that we know that have tried to get codes put through. So sort of to walk through as a bill becomes a law, if you have a new procedure you want to have turned into a level 1 code and to be valued to get reimbursed by Medicare and Medicaid, that's really what we're talking about here. You have to have a level 1 code. Anybody can submit a code, not just any doctor, anybody. Like guy off the street wants to submit a code to CPT Editorial Board, they can do that. Now, ACOG's role in that is to be supportive, help you fill out the application, understand what the sort of, not just like what the requirements are, but understanding the politics of how this is going to potentially go. And ACOG joining you at the table is a very powerful statement that ACOG supports it versus I got this idea, I want to blow up all the hysterectomy codes and rewrite them. ACOG's going to think a little bit about it. And they may say, you know what, we're actually thinking that's not great for our providers. And so then you're going alone up to the CPT Editorial Board to ask for this code, which is unlikely to be approved. So ACOG's role is not that we approve the code. ACOG doesn't sign off on anything and say this is a code or not. The CPT Editorial Board does, but ACOG's support in that process can be very helpful. And it's not just ACOG, it's ACS. If it's a surgical code, there's all these things.
Yes.
So
is the RUC, like the RUC is separate from the CPT Editorial Board? Okay.
So CPT is a procedure code or not? That's all, right? So yes, if it's a level 1, it's a thing that we can now try to value. Once it's level 1, then it goes to the RUC to get valued. And that, y'all sent me to one of those meetings and I thought I was being punished. that they're both interesting meetings, but the RUC is a closed door meeting. So the AMA was given the right to make the codes from the federal government, from CMS. The RUC is like, it's a closed door meeting where a bunch of doctors got in the room and said, how much is this stuff worth? And then they told the federal government, and they said, okay, historically, right? They just sort of took their...
In the very early days, I would
days.
say that was true. RUC meetings are now open.
Oh, okay, they are.
They're confidential, meaning that you have to sign up and you have to sign a confidential. I mean, think about this. If you're a company, your stock value will depend on recommendations that the RUC may or may not accept. So it's highly confidential. People have to sign confidentiality agreements if they're going to participate in those meetings. But the meetings are not closed door with the cigarettes and the cigars and all that, and the martinis.
I got in too late.
Yeah, they were not like that when I got there either. But the job of the RUC is to take it's almost 8,000 codes now, and rank order them. Put them into some valuation strategy that makes sense. And so over the many years since 1992, the RUC has come up with a lot of systems to try to help us be really thoughtful and also consistent. So there are now consistent pre-surgical packages. You know, if you're doing a 90-day global surgery, the pre-surgical package, like the work you have to do, will depend to some extent on how sick your patient is and some other things. So there are packages of things that we can just plop in for consistency. But where the rubber meets the road is the intra-service. What is this procedure? And so by law, RVUs are defined only by time and by intensity. And that is the law, which really hurts us when we do things like move things from the hospital to an outpatient environment. Where we used to have to make rounds in the hospital, we were getting RVU credit for that time that we spent making rounds. and seeing patients. And even though we have saved the system money by moving patients into outpatient settings, we shot ourselves in the foot in a way because those RVU credits for the hospital stay no longer apply.
So can we talk about what, when we say RVU, relative value unit, and a lot of hospitals and physician reimbursement is based on an RVU model, and most of us don't really know what that means, relative value unit, and it's made up of multiple components, right?
Right. Yeah. So there are three components to the total RVUs for a procedure. There's the work component, which is what we've been talking about, which is the time and the intensity and how is it relative to other things. But that's only half of the payment. The other half, it relatively is practice expense. And so the calculation for practice expense is really, really difficult. I kind of think I'm smart about some of this stuff. I have never been able to make that calculation work. But the practice expense component considers the place of service. So is it in a facility or in your office? And those practice expense RVUs are different. And then there are direct practice expenses. What does it cost to do this procedure by itself? The equipment. So as an example, the new public examination code that came through this year. So we have a new code that's a practice expense only code that pays OBGYNs added dollars. It's about $24 in Medicare for the cost of doing a public exam, the speculum, the additional cotton balls and all those things, having an extra person in the room.
When did that start? January 1?
Started January 1. And the reason was that the RUC was looking very carefully at equity between male procedures and female procedures. And the RUC said, the preventive services codes are gender neutral. They're age specific, but people who do women's health do public exams on every patient. And that's inequitable because they cost more.
They do cost more. I just wanted to ask about that because that was brought to our attention. But then if you dive into it, it's only for non-facility.
That's correct. So let's get even further into this now. There's a real advantage to doing things in your office. And when you are a physician practice that's owned by a health system, the health system bills a facility fee for every encounter that we have. And in the cost of that facility fee are the expenses for all of those things. So we, the physicians, are not incurring that expense because we don't own the staff, we don't own the equipment, we don't purchase the equipment.
So the work RVU doesn't change no matter where you are, right? If I'm doing it my office, the hysteroscopy in my office, if I'm doing it in the OR, if I'm doing it in the ambulatory surgical center, the work RVU is the work RVU is the work RVU. What matters is the site of service and the facilities. And having watched for hours people debate over how many shoe covers were needed for a particular procedure, I mean, fractions of pennies. But when you're paying for millions of these procedures across the country, that as the federal government does, like that stuff adds up. And that was the part of it that just blew my mind. Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.